Good afternoon, everybody. So today from Pediatrics Unit 3, from the Division of Pediatric Oncology, we'll be presenting today's CGR that will be focused on our survivorship services that have been developed over the past 15 years. Just to give you a background, the flow will be that we'll be giving you some basics on our data of Indian as well as worldwide data, demographics, functioning of our clinics, the commonly observed late effects, how we evaluate our newer initiatives, our teamwork, philanthropic collaboration that we have, and also the contributions that we have done at the national level. And this will be the flow of the CGR today. If you look at the global data, this represents almost the major load is taken by acute lymphoblastic leukemia, closely followed by brain tumors. This is the global data. But then regional variations are known, also seen at our center, where we see after acute lymphoblastic leukemia, retinoblastoma is our commonest tumor that we see, and this is over the decade that we have seen. So regional variations are known, and this is typified by our center. Global incidence of childhood cancer, the annual load is almost 400,000 new cases are seen globally. But what is interesting to realize is that over 80% of the newly diagnosed children are seen in the lower middle income countries. All the shades of light as well as dark orange represent the lower and middle income countries, and 80% of the load is shared by these, and the rest, only 20%, are represented in the high income countries. But how does this translate into a survival data? So there's a great disparity in survival. So almost 80% of children emerge as survivors, as long-term survivors in the high-income countries, versus almost 30 to 50% is the range that we see in lower and middle-income countries. But at the same time, we need to realize that improved survival rates are the trends now, and also is seen typically in our country. And our survival rates are increasing, are improving, resulting in a growing population of childhood cancer survivors. So what is survivorship, and why are we talking of a survivor? So how do we define a survivor? So there are actually legal, practical, clinical, at the advocacy, there are various definitions. It has heterogeneous connotations. So, but to understand, anyone with cancer, regardless of what stage of treatment they are going through, is a cancer survivor for us. But a practical clinical definition, as we'll be focusing in today's presentation, would be a survivor whose disease, whose cancer is in remission following the conclusion of treatment. Survivorship is a concept, is an off-therapy program. So it's something that starts with diagnosis. It's the entire process of living through from the diagnosis till the treatment, and also life beyond that. Life beyond that forms an important component of the survivorship program. You navigate your experiences, your life, the family navigates along with you, and it's a multidisciplinary engagement. It's an acute, it can be divided into acute, extended, and permanent survival. Acute is when your focus is only on achieving remission. From diagnosis to remission, the immediate focus. Then is your extended period where you've achieved a remission. It's the period of waitful observation, where you're just observing. The child is under surveillance, that if the disease should not come back. So your target is to keep the child under surveillance. Then comes the state of permanent survival, which is most important for us, where the children emerge as long-term survivors. This is beyond 5 years, where the chance of recurrence of the primary tumor is very low. Then the other late effects also, particularly the second neoplasms, come into picture. So that is how we divide survivorship, and all phases are equally important for us. Improved survival comes at a cost, and these costs are chronic health conditions. Earlier, these were known as morbidities, late effects, but now it's something like the term of chronic health conditions are becoming more popular. These are late effects, and you can see these can take various organ systems can be affected, and these all survivors are at a higher risk of reporting a chronic health condition as compared to normal age and sex matched controls. These chronic health conditions are actually the late effects, okay, and these are unrecognized toxicities which are absent or subclinical in the initial phases of treatment, but then will emerge sometime when the treatment is over, during survivorship. And it is the Western data suggests that almost 2/3 of the childhood cancer survivors will experience at least a late effect, one of the late effect, and 1/3 of these are going to be life-threatening. But this is all Western data, and we are extrapolating all this from Western data. We need to form our own data. Hence, there is a need for systematic long-term follow-up of our childhood cancer survivors and need to generate Indian data to form our own data, our own guidelines for long-term surveillance. So then comes the concept of how do you follow them long-term. So various survivorship models have been put forth. Some are oncology-led, some are shared care models, and the most popular ones are the survivorship clinic models. So it is this clinic that we are going to focus in the rest of our presentation. So we have started this clinic in 2006. It's a weekly clinic. We were the second in the country to start it. The first was by TMH Mumbai, and we've really grown. We really started with one physician, that was the pediatric oncologist and a resident, and now we have, I was calculating, more than 25 people who man the clinic. And this is one of the first files in 2006 that we saw. It's a very sketchy type of a note that you can see. Now everything is very structured into all the treatment details, all the exposures, then all the treatment summaries, and then what the late effects are likely to occur, and all the surveillance plan and the follow plan is all given to the patient once he enters into this permanent survivorship. And if you can see, in 2007, we had less than 50 patients who were emerging as survivors in 1 year. And our disease profile comprised of primarily leukemia, lymphoma, and retinoblastoma. Then we have grown, and almost in 2016, this was an important year for us because it was the year when the first childhood cancer survivor registry was inaugurated, and it was came into vogue. And then, of course, there was the numbers have continuously increasing. 2020, yes, there was a dip. This was understandable because it was somewhere around COVID time. Then in 2017, we had another milestone. We started with our transplant services. We have a lot of transplant survivors. Then in 2021, we extended our services, and the oncofertility program and fertility preservation techniques which were offered to our patients came into practice. And then, of course, in 2022, our neuro-oncology program also came up in our survivorship services. So that's how we have grown. And this year in 2023, we had almost 171 survivors who were registered into our survivor clinic. And now you can see the spectrum of malignancies that we are catering to. We started with just 3, and now we have a full spectrum of malignancies that we are seeing. So with this background, I invite Dr. Jagdish to give you a detailed glimpse of how the survivorship clinic runs.
Thank you, ma'am, and good afternoon, everyone. So I will discuss our survivor clinic. The focal point of our survivorship follow program is our pediatric cancer survivor clinic. We run this clinic on each Thursday afternoon in pediatric OPD. After having completed therapy, each patient is registered into this clinic. Their treatment details is reviewed, summarized, and follow plan is formulated. Each patient after enrollment in this clinic is provided an ACC card which has details of therapy which includes radiation dosage and cumulative dosage of chemotherapy and expected late effects. This model is being followed by many other centers. On subsequent follow-up visits, children are assessed for growth parameters. If any intervention is required, the support is taken from our unit's nutritionist. Few of the selected patients are referred to our pediatric endocrinology team for further workup and management. We do a lot of counseling to our survivors for healthy lifestyles. Like they should have a balanced diet which includes vegetables, fruits, whole grains. They should refrain from alcohol, smoking, and tobacco. We encourage them to do regular physical activity and exercise. They should maintain healthy weight because they are more prone for obesity and various metabolic syndromes. They should have adequate sleep and reduce stress. Revaccination is planned after an appropriate treatment duration and is continued subsequent follow-up visits. We revaccinate after 6 months of last chemotherapy dose and autologous transplant, and after 1 year of allogenic transplant. Children are next assessed for neurological development and psychiatric issues. Children who are at high risk for neurocognitive, behavioral, and psychiatric issues are assessed formally on regular periods. Integration into formal education is utmost priority of our survivorship program. With the help of psychologists and various numerous educational grants from non-profit organizations, we ensure that children resume their learning and receive specific aids as required. Specific end organ dysfunction are reviewed on follow-up visit at each plant during the enrollment in survivorship clinic. As this is a prototype of Hodgkin survivor patient, these patients are exposed to bleomycin, which can cause pulmonary toxicity, and this patient here, spirometry is being done here to rule out pulmonary toxicity. This is also a Hodgkin survivor patient, which is exposed to anthracyclines. Echo is being done to rule out cardiac toxicities. The third patient is Down syndrome with acute leukemia survivor patient. Our resident is performing neurodevelopment assessment here. When late effects is identified, support is taken from other disciplines to tackle the same. After enrollment in survivor clinic, after PCC file completion, each patient is discussed in the team, follow-up plan is made, and counseling done to the family for the expected late effects and for the follow-up plans. While resuming normal life is one of the priorities of our survivorship program, we also keep a close watch up on secondary malignancy and disease recurrence. Ultimately, the family embarks on the journey of the cancer survivorship alongside the patient. With the assistance of our social support team, we identify potential social and economic stressors for the family and direct them toward support resources. Thank you.
Thank you, Dr. Jagdish. So with this now we move on to the next section where I'll invite our residents to discuss and present some of our data pertaining to cognition, psychosocial, metabolic, and pulmonary as well as cardiac late effects that have been seen in our survivor population.
Good afternoon, everyone. I am Dr. Kritika and I'll be discussing briefly the neurological and psychological late effects. There's a variety of pathways through which we have neurocognitive late effects in cancer survivors. They usually revolve around neuroinflammation as well as the direct neurotoxic injury and endothelial dysfunction because of a variety of causes. The cancer treatment per se, the location of the tumor, age and comorbidities, and of course the weighty psychological and social factors that occur during the course of this treatment. Patients who receive cranial irradiation have been found to have a decline in their full-scale IQ. And the interesting thing about this is that the decline continues well after the completion of therapy. We know that it does continue at least 10 years post-treatment completion. Exactly at what point it stops evolving is still unclear to us. Chemotherapy-only protocols also have up to 1/3 of the patients showing deficits, though it's not usually an obvious full-scale IQ deficit. It's usually in more subtle things like visual motor functioning, executive functioning. The high-risk groups that have been delineated by the Children's Oncology Group include diseases where we have CNS-directed therapy, like all our leukemias, non-Hodgkin's lymphoma, all brain tumors, and any head and neck region tumors that receive radiation. Some patient-related factors, of course, patients who are younger at the time of diagnosis and therapy, because this is the maximum age at which neurodevelopment occurs. Increased time since completion, we know, as we've discussed before, because the deficits continue to progress well after therapy. There are some genetic pathways that have also been discovered, like glutathione S transferase and folate metabolism enzymes that make people more susceptible to neurocognitive deficits. Modality related, of course, we all know that cranial radiotherapy is one of the important modalities that can cause neurocognitive dysfunction. Other things include chemotherapy like high dose intravenous and intrathecal methotrexate, cytarabine, and corticosteroids. Just to give you a brief outline of the global burden, firstly, let's come to India. This is a study of more than 3,000 survivors from the Tata Memorial Hospital, and they had a median follow-up around 11 years, and they actually found that 57% of their patients have psychosocial issues and 4.1% have neurocognitive impairment. At the world level, this was a long-term survivor study. More than 2,000 patients were studied, and they were compared to around 200 siblings, and these were in more subtle areas like task organization, memory, executive functioning. And as you can see that the percentage of patients who have these deficits is much more in ALL with cranial radiotherapy and CNS tumors, more than 1/4 of patients in these. Whereas those who are treated with chemotherapy alone, it's more in the tune of 10 to 15%. Height. This is just in comparison to the siblings. As you can see here, the relative risk of developing deficits in any of these domains is significantly higher in patients who are ALL, who received cranial radiotherapy, as well as CNS tumors. So these we know are our main targets of intervention. This is our unit data. So we studied 70 patients who were ALL survivors. These were short-term survivors within 2 years post-therapy completion. As you can see, more than 50% belong to either the average or the below average group in terms of full-scale intelligence quotient. And what's interesting to note is when we studied the risk factors, rather than disease-related factors or treatment-related factors, the main things that really stood out are socio-demographic factors. So we found a significant association with socioeconomic status, maternal education, paternal education, and birth order. These were significant factors that influence the developmental neurocognitive deficits. The road ahead for us is we now have an ongoing study on neurocognitive deficits in long-term survivors, that is more than 5 years post-therapy completion. We will continue to do a baseline periodic examination and assessment of all our high-risk patients, and those in whom we detect late effects, of course, there'll be a more close follow-up. Now that we have CNS tumors as a growing group in our survivor cohort, then there has to be specialized streamlining of follow-up for them. And of course, improved screening of hearing and vision deficits, because these play a very important part in the neurocognition later in life. Just briefly also about metabolic late effects, which is also a very important thing in our survivors. So through a combination again of inflammation due to cancer treatment, as well as some deranged adiposity, usually due to a large amount of corticosteroids used, nutrition as well as physical inactivity that usually occurs during the course of cancer therapy, what we find is that the children have a pattern of obesity called sarcopenic obesity, which is basically they develop central obesity with very poor muscle mass. So this in the future does lead to frailty and a poor quality of life. The other thing that is known is because of this visceral adiposity and pro-inflammatory adipokines, these children in the long term develop metabolic syndrome, cardiovascular disease, and diabetes. Again, high-risk groups are similar to those for neurocognitive development. They're children with ALL, children receiving any sort of cranial radiotherapy, and recipients of transplant. The global scenario in this is a large study from the St. Jude Lifetime Cohort Study, and what they have found is they assessed upwards of 1,500 participants, and they looked into, this is the World Cancer Research Fund recommendations for lifestyle. This includes diet, exercise, and other good lifestyle practices, which are ideally were put forward to prevent cancer. So they just wanted to see how many of these survivors actually adhered to this later on in life. What they found firstly is more than a third of males and females actually have metabolic syndrome, which is a large number. And survivors who did not follow these guidelines actually had a much higher chance of developing metabolic syndrome. So this means that diet and lifestyle is actually a very key area of intervention for us in our cancer survivors. This is our unit data. So we looked into prevalence of metabolic syndrome in our survivors of ALL, as well as the utility of using serum adipokines as an early biomarker. As you can see, compared to the controls, which were 40 siblings of the survivors, there is definitely significant derangement of lipid profile, as well as in the incidence of metabolic syndrome in our cancer survivors. The serum adipokines of leptin and adiponectin actually did not vary significantly, the median levels. But when we did a multivariate analysis, we found that serum leptin levels were significantly associated with metabolic syndrome. So I think a larger study may give us some interesting results on whether this is a useful marker or not. The road ahead is firstly all dietary interventions to all our survivors after assessment of baseline nutrition with the help of our nutritionist. And of course, patients who are at higher risk or who are showing any signs of abnormal weight gain or malnutrition at that point. And we also have an unpublished study right now on bone health of our survivors, and we plan some targeted interventions for the same in them. I'd like to now call Dr. Himani, who will get into psychosocial late effects seen in our cohort.
Now, briefly talking about another pivotal facet of the survivorship care plan in our cancer survivors is that is the psychosocial late effects. If we carefully look into this health-related quality of life model, we can make out that psychological well-being forms one of its 4 core domains. This is because they influence our survival life in a big way. First of all, these children may face difficulties in developing harmonious relationship with their peers. Secondly, they may also have to face few adjustment problems during their school life, leading to poor scholastic performance and increased dropout rates. And also, they may lag behind during their extracurricular activities. Last but not the least, and more important though, they usually lack a smooth transition to the early adulthood. So all these culminate into their future lifestyle and occupational plan disturbance, leading to social and economic concerns, leading to underemployment, hiring discrimination based on the employer's attitude about their illness, and also they face difficulty in obtaining health and life insurances. In addition to that, issues of infertility also. So it makes prudent for us clinicians to regularly examine these children for the psychosocial late effects on a regular and periodic manner. According to Children's Oncology Group, they have divided these psychosocial late effects under 4 main broad headings. The first main group is the other disorders pertaining to quality of life. Another important group includes the mental health disorders. The third one is the disability due to pain, and the last one is the risky behavior. Why it is important to know when we are selecting any screening tool for assessing these children, we should always keep this diagram in mind, so as we should select an appropriate tool which should comprehensively cover all these 4 domains. Now, looking into the risk factors, these disorders usually result from the interplay between host-related, treatment-related, and certain social factors. Noteworthy in host-related factors are female gender, family history of a mental illness, any pre-morbid learning or emotional difficulty, importantly, children with CNS tumors, and those who already have a poor perception of their clinical health in chronic pain. The treatment-related, the most crucial risk factor is CNS-directed therapy in the form of a cranial radiotherapy or a high-dose chemotherapy. The next is children undergoing hematopoietic stem cell transplantation or having a major surgery having a brain-bearing effect on their brain. And the social factors into low socioeconomic status, lower educational achievement, underemployment, and lack of health insurance. Now, looking at the burden of these effects, if we look into the Indian scenario, there is very limited data from India which reported average quality of life in 38% of the survivors. Another studies have reported nearly half of these children have psychosocial problems, and marginally less than half have poor scholastic performance, and 3% of these children needed intervention. There's a study from our center also. They also have reported nearly 50% of the survivors are socially withdrawn, anxious, and depressed. Coming to the global scenario, if we look from the results from the 4 main consortia which we have in a survivorship cohort, the results from all these 4 consortia are on the same page and have reported lower health-related quality of life, increased incidence of anxiety, depression, and fatigue in the childhood cancer survivors as compared to their age and sex-matched counterparts. So all this provides us a riveting evidence to include the surveillance for these psychosocial late effects in a survivorship care plan. So these are the various tools which we can use for assessing these disorders. Depending upon the availability and the clinical expertise of the person who would be performing, we can choose any one of these as per the center's suitability. Now, a brief sneak peek into what we are doing here. At our PCSC clinic, we have a dedicated child psychologist. She screens all the cancer survivor children who are visiting during their routine follow-up visits in our clinic using an interview-based questionnaire along with certain screening tools pertaining to assessment of fatigue impact, extent, distress, and pain. This is the template of our interview-based questionnaire which we are using in our clinic. This is for assessing fatigue extent and impact. We are using symbolic assessment scale. For assessing the distress, we are using pediatric distress thermometer, which looks into all these important core domains and classifies survivors under 3 categories, starting from no distress, moderate distress, and high distress. And for pain, we are using this basic face pain scale in our clinic. So, based on our experience till now, we have data for around 302 cancer survivor children having various underlying malignancies, including hematolymphoid and solid tumors. Over a variable time period, we have started listing of these survivors since 2016. So, what we have observed till date now is that survivor children are doing fine. Most of the time, they have only mild to moderate evidence of these mental health disorders. And once screened for this mild to moderate level of disorders, we usually offer them a serial counseling sessions in our clinic also. And if needed, based on the if they are having any mental disorder, then we seek help from our psychiatric colleague. So to sum up at the end, I would like to re-emphasize the importance of these psychosocial late effects, their early screening, diagnosis and management, so as to make our survivor children a suitable, acceptable and productive part of our society so that they can cherish their life moments and first-hand experiences. Thank you. With this, I would like to invite Dr. Prashant to carry forward the discussion.
So I'd like to talk about cardiac and pulmonary late effects. As far as the cardiac late effects are concerned, these are actually the most common late effects which has impact on morbidity and mortality of the survivors. So the most commonly implicated drug is anthracycline, and nearly 60% of our cancer survivors are actually they have some or other way they are exposed to anthracyclines, be it solid tumors or hematolymphoid malignancies. And not only the anthracycline, the other agents that are implicated or other are the radiation therapy, even the cyclophosphamide, the high-dose Ara-C or the cisplatin are also implicated in the cardiac toxicity. Now, coming to the spectrum of cardiac toxicity, it is not only the congestive heart failure or cardiomyopathy. The other spectrum are it can lead to arrhythmias, the valvular heart disease, or the coronary artery disease. In fact, as the survival increases, as we can see in this chart, that by the age of 45 years, almost 5% of the survivors actually has coronary artery disease, and they have heart failure or valvular heart disease. So the drugs that are implicated in this are the anthracyclines and the radiation. And as the exposure of different drugs are there are various spectrum, as we can see. Now, the most important part is the modifiable risk factor, that is the hypertension, diabetes, the dyslipidemia. So the main role of the survivor clinics comes here, where we can modify the risk factors so that they have less cardiac toxicity and they can lead a good life. Now, in fact, it is one of the most common relapse cause of mortality in cancer survivors, and they are at 7 times more risk of cardiovascular disease in cancer survivors. Now, the mechanism is more or less not known, but as far as we know that it is mainly due to the redox reaction leading to the generation of reactive oxygen species, which ultimately leads to cardiomyopathy and the apoptosis of the myocytes. Now, who actually needs surveillance? The recommendation is to do surveillance of all the patients, but who are at the highest risks are those patients who are actually exposed to the anthracyclines at more than 250 mg per meter square. As we can see, this graph has a steep rise when the dose is more than 250 mg per meter square. And if the radiation dose is more than 35 gray, then they are at higher risk. And if the exposure is more than 100 mg per meter square, but radiation is more than 50 gray. So these 3 cohorts of patients are those who are at highest risk. And the recommendation is also to screen for all those patients who have any exposure to the anthracyclines. Now, coming to the next, what is the COG recommendation? So the COG recommends that all those patients who are at higher risk of cardiotoxicity, they'll be screened every 2 yearly, and all those patients who have any exposure to anthracyclines and exposure to radiation therapy less than 15 gray, they'll be screened every 5 yearly. We are also following the same protocol, and the dose modification, that is the dose calculation, is based on that formula where we calculate the equivalent doxorubicin dose based on the multiplication factors. Now, coming to the outside study, this is one of the largest study done by St. Jude's Lifetime Cohort. They actually followed the patients of Hodgkin's lymphoma till they have completed at least 5 years of treatment. And what they found that at 50 to 55 years of age, these patients have a significantly higher risk of cardiac morbidity and mortality. And in fact, almost 45% of the patients actually develop some kind of cardiac morbidity. Now, coming to our unit data, we have actually analyzed around 463 patients, and out of these, 290 patients were eligible for our analysis because they had some kind of exposure to the anthracyclines, and rest 173 we excluded who had no exposure to the anthracyclines. And the median age of presentation was 7 years, and 76 were comprised of male, and at a median follow-up 76 months, that is around 6 or 7 years of follow-up, the major chunk of the patients were formed by the ALL, followed by Hodgkin's lymphoma, AML, and non-Hodgkin's and Ewing sarcoma. And out of these total patients, almost 22 patients had a chest RT, almost 25 to 30 gray chest RT they received. And the median anthracycline dose was 260 mg per meter square. And almost 4.5% had some kind of cardiac dysfunction, and majority were subclinical cardiac dysfunction detected on echo. Now, the diagnosis of those patients who actually had this cardiac dysfunction, out of these patients, 6 patients were Hodgkin's lymphoma patients, 3 had Ewing sarcoma, and they have received chest wall RT, followed by AML, ALL, and the median anthracycline dose was 300 mg per meter square, and almost half of the patient had received chest RT, and the median age at receiving this RT was around 6.8 years, and almost 40% of the patients were female. So now coming to a few words on pulmonary toxicity, apart from the radiation, the common drug implicated is bleomycin, which leads to interstitial damage leading to pulmonary fibrosis and pneumonitis. So our data, we have analyzed 60 patients of Hodgkin's lymphoma, and their median age was 11 years, and we found that almost 18% of the patient had some restrictive pattern in the pulmonary function test, although they were asymptomatic. So the coming years, if you follow those patients, probably they will give more data. And the significant factor that was responsible for this toxicity was age more than 10 years, and if they had a significant past history of any respiratory illness, and mediastinal RT, although it was not significant, but it was reaching significant. If they had received mediastinal RT, then they had significant pulmonary toxicity. Now I'd like to invite ma'am to show.
Thank you, Prashant, Kritika, and Himani. So now in the past 10 minutes or so, you've seen our description of the already established late effects. But now we want to spend project few of our newer initiatives, which would comprise of our CNS, the neuro-oncology program, the oncofertility program, the fertility preservation techniques, and also our initiative and our progress that we've done for our transplant patients. So with this, I invite Shivam to first cover the CNS tumors.
Thank you, ma'am. Beginning with these CNS tumors in itself, survivorship in pediatric CNS tumors is a little recent concept as compared to the other malignancies. Although the pediatric CNS tumors form the second most common group and the most common cause of mortality. With regards to the late effects, specifically for the pediatric CNS tumors, the first and foremost is the neurocognitive late effects. Now, this was described in detail in the previous sections, and the data I'll be showing in my subsequent slides. Then comes the psychosocial aspects, which are quite predominant in the CNS tumor cohort, including from the mental health to the acceptability in the society. Coming to the functional outcomes in the form of cerebrovascular and cardiovascular, endocrine abnormalities, and peripheral neuropathy, and ototoxicity as well. So you can see multiple systems being involved in the case of as a late effect of a CNS tumor. Then second, malignancy in itself. So either the progression of the primary disease if it was in a stable condition, or it could be a second malignant neoplasm of the CNS system, or thirdly, leukemia secondary to the chemotherapeutic drugs which are used in the management of the CNS tumors. And last but not the least, rather far from least, would be the fertility and the reproduction, which is an upcoming concept. And CNS tumors are a very important group of tumors which do incriminate in leading to infertility. So to understand the pathophysiology, now these many myriads of late effects are secondary to the multimodal management of CNS tumors. So it begins with the structural lesion in itself. So the intracranial lesion would cause a neurological morbidity and the cognitive late effects. Then treatment related would be radiotherapy. The radiotherapy is the backbone of almost all CNS tumors. And with this, there will be multiple medical and the functional late effects. including many organ systems. Then surgery, causing neurocognitive deficits, and endocrine deficits are a major chunk if the primary tumor is involving the diencephalon region. Then chemotherapy associated late effects, because the most common drugs being used are the platinum compounds. So they'll lead to ototoxicity, infertility, endocrine abnormalities, and metabolic effects secondary to agents used in the management of the CNS tumor. So beginning with the global data, so this was a data well published in 2007, and it was the largest data as of now which we have from the St. Jude's cohort. So it was a St. Jude's cohort of almost 650 pediatric patients with a primary CNS tumor, and they were enrolled from a period of 1985 to 2000, data published in 2007, and they were included when they had completed 5 years of surviving from the time of diagnosis of the cancer. So in their cohort, the baseline characteristic included that the males were predominant, and they had a significant, around 25% of the cases were infant cases, so 0 to 2 years. In CNS tumors, usually you categorize them at infant at the age up till 2 years instead of 1 year, because of the management similarities. Then coming to the management part, surgery was the foremost. So 90% of the cohort underwent surgery, and the most common were the low-grade gliomas, second being the embryonals, which include medulloblastoma, and then the ependymomas. And posterior fossa was the most common location. The overall survival of the cohort at 10 years was 90% and 15 years was 85%, and the standardized mortality ratio, which compares from the aged and the gender matched controls from the healthy population, was 28, means 28 times. So the study population had a 28 times more chances of mortality, and this was dependent on the histology. So the best outcome was with the low-grade gliomas, which were the most common, thankfully, and high grade having the worst outcome. And the most common cause of death, so there were 10% deaths reported, and the most common the reason was progression. Then secondary, there would be some second malignant tumor, some medical condition, malignant transformation, and external causes. Now here I'm focusing on the medical condition because this is the area where you can focus, where you can actually intervene and screen them out. So the medical conditions were mostly involving those who had the tumor at the diencephalon region, and there was a problem of panhypopituitarism where you need to screen them up and you need to intervene accordingly. The metabolic causes and infection related were the most common causes of death among the medical causes. This is another study recently published a year back and published in JCO, a well-reputed journal, and regarding the survival outcomes of the medulloblastomas. So 5-year survivors, and between 1987 to 2015, and then again they were age matched and with the controls of around 1,000 controls. And you can see, as per the hazard ratios and the figures given, that the mortality, stroke, ototoxicity, disability supports being taken from the government, the claims, hypertension, and also the infertility aspects were significantly more with the study cohort as compared to the population. So this comes to our unit experience, what we have seen. So this is an unpublished data, and which accounts for the outcomes of pediatric CNS tumors evaluated from January 21 till August 2022. And we had a cohort of 41 individuals, and most common were gliomas. Our cohort, we had more GCTs with us. We had intracranial GCTs I'm talking about, and then medulloblastomas, and last were the ependymomas. So the surgery was performed in almost 80% of cases, with mostly 50% being the subtotal resection, rest being the near total or gross total, and adjuvant chemotherapy in 40% cases, and radiotherapy in almost 1/4 of the cases. The survival, the follow-up was around 2 years, with a median overall survival of 400 days. Sensory deficits seen in 30% cases, and motor deficits in 20, with endocrine deficits also seen in a significant proportion, 15%. So this comes to the challenges which we are facing, and what did we identify as soon as we started seeing pediatric CNS tumor? So we started from 2021 May, and we did find that there was a high attrition to follow up post-surgical management, because the point of contact of the CNS tumor patients would be a neurosurgical discipline. So from there, post surgery, some or the other reason, there is an attrition. There is loss to follow up. And because surgery is not the only cure, there is a multimodal aspect, due to which there was a problem statement which we find, and then we didn't intervene, and we did make a formal monthly tumor board which comprised of the neurosurgeons, the neuroradiologist, pathologist, and our team, and we started this from May 2022. Neurocognitive late effects, one of the most common late effects of across the entire globe. And for this, we intervene in the form of, we have a neuropsychologist dedicated as a part of our team, and there is regular monitoring. And we have a framework of the system starting at the diagnosis, after every 2 cycles, at the survivor, at the survivorship file when being made, and then as per the protocols, regular follow-up. With the hearing late effects, autoacoustic emission and the BERA being performed routinely in collaboration with the ENT department, because this was a significant medical late effect seen. So with this, I come to the another important recent intervention which we started doing, identified in the pediatric cancer survivors, was fertility preservation. So from the oncological aspect, as an oncologist, I'll just introduce, and then I'll go ahead with the story. It begins with the pathophysiology begins with, again, because of the chemotherapy, because of the radiotherapy. So with regards to chemotherapy, these are the high-risk chemotherapy agents. It includes cyclophosphamide, one of the most common agent being used in pediatric tumors, both solids and liquid. We have procarbazine, nitrogen mustards, melphalan used in our transplant setting. Then ifosfamide, busulfan. Among the intermediate risk, we have platinum compounds and anthracycline again, and these are the lower risk. And these are the cumulative doses, so here which differs gender-wise, and these are the agents which are used. So if you collate this data, you would find many of the malignancies treated in the pediatric age group are incriminated to lead into infertility. It begins from high risk and intermediate risk ALL, all AMLs, multiple solid tumors including neuroblastomas, Ewing sarcomas, osteosarcomas, and even RMS. So major fraction would be involved. And with regards to RT, it actually depends upon the treatment age, the radiation dose, fractionation dose, it either a direct injury to the ovary or a scatter, then uterus injury, in which TBI is a total body radiation, which in itself will cause a permanent infertility and changes at the uterine level, and then at the brain level. So this is just a representation of a high risk versus low risk. So any female receiving a pelvic RT for abdominal tumors like AIIMS or neuroblastoma, more than 15 grays in prepubertal, more than 10 in postpubertal, and TBI or cranial RT, more than 40 grays. So for all pediatric CNS tumors, they would be receiving, most of the major groups would be receiving a cranial RT of more than 40 gray, leading to a permanent infertility. But the male, it would be dependent upon the dose of the radiotherapy, like 6 grays for testicular RT, 1 to 6 would be intermediate risk, and low risk would be less than 1 gray. But any TBI or cranial RT would give you a permanent infertility. So with this, I begin with a case that there is a 14-year-old female child. It's an actual case which we had, and limping for 20 days with fever. And these manifestations, we did make a diagnosis of a right-sided Ewing sarcoma, and the child was soon to be started on a VDC-IE-based chemotherapy. So this was as per our protocols, the childhood oncology group protocol. And then the child would be a candidate to receive radiotherapy. So is this child at an increased risk? Yes, because of the ifosfamide being used, and again an RT to be delivered at the pelvic region. And if yes, what can we do? So for this, I would like to invite Professor Neeta ma'am from the Department of Obstetrics and Gynecology to actually guide us and take us through the journey.
Thank you, Shivam. Good afternoon to everyone. So we are discussing about the survivorship and life beyond cancer. After having improved diagnostics and the treatment in the childhood cancers, many of these children are going to be adult and they are going to enter into family life. And the issue of fertility has to be discussed before we embark on giving them radiotherapy and chemotherapy, because once they receive these radiotherapy and chemotherapy, there is no way we can bring their fertility back. And therefore, we have to address this issue. We have to generate the awareness, and we have to discuss with the parents and the children about preserving their fertility so we are able to give them a productive and a fruitful life as parents. So I would request my DM fellow to present our data, which we started this clinic 2.5 years back when I did a international conference on fertility preservation, and me and Dr. Rachna sat together that we have to start this program for our survivors of childhood cancers, and then we began, and we have about more than 100 patients we have offered the fertility preservation. So the need for preservation in the pediatric population is being discussed, in which the cancer patients undergoing toxic treatment or surgery need fertility preservation. It can also be needed in benign conditions or when gonadotoxic treatment or any surgery, or in patients with fragile eggs or Turners. So this is one ASCO guideline which says that the provider should advise patients regarding potential threats to fertility as early as possible in the treatment process, so as to allow for the widest array of options for fertility preservation to be available to the pediatric population. So male fertility preservation, we have two main options. One is banking, which is gold standard, which is easy in adult and postnatal male patients with cancer, which should ideally be done prior to starting chemotherapy and radiotherapy, and 2 to 3 ejaculated samples are cryopreserved. However, testicular tissue cryopreservation, which is still experimental, is the option that we have in prepubertal boys. So, we have a study showing that a sperm sample was preserved 26 years back, which has been used for ICSI, and then there has been a live baby with it. So, yes, the duration does not really matter much. So, this is one case of a 9-year-old boy who was diagnosed with Hodgkin's lymphoma with stage 4B bulky disease and had received chemotherapy, followed by there was testicular transposition done, and both the testes were repositioned, and then the patient received radiotherapy, and post-radiotherapy, the testes were repositioned to the scrotum. This is one example of one of the cases which was done for fertility preservation. In the female population, the most important part is counseling about the risk of infertility which the treatment may cause to them. Is fertility preservation really necessary? And what can be done? And should it be done before starting their cancer treatment or after that? And what are the options available? So we have to start with the hormonal analysis, that is serum FSH, LH and AMH, and we do an ultrasonography to see for the antral follicle count and the ovarian volume. And these are the various techniques which are available with us. One of which all of these are first is in vitro maturation, in which they stimulate the ovaries for around 4 to 5 days, and once the follicles are around 10 to 12 mm, then we retrieve the oocytes, mature them in vitro, freeze them, and later they can be used for IVF using ICSI. The second option, the most standard, is oocyte cryopreservation, which we routinely follow. However, the stimulation here takes 10 to 12 days, which is followed by a pickup and cryopreservation. Ovarian tissue cryopreservation is no more experimental worldwide. However, we have just started with it as a study project. Ooperopexy is another option in which the ovaries are suspended out of the field of radiation, and ovarian suppression is one option in which GnRH analogs are used. This is one study which can see that the oocyte, which was cryopreserved 14 years back, has been reused, ICSI has been followed, and a live baby has been delivered. So these are some challenges in which usually the pediatric population is referred after receiving chemotherapy or radiotherapy, and the associated social stigma and the monetary constraints. The cost for sperm cryopreservation is 5,000 annually, and for oocyte cryopreservation it is 60,000 once, which is followed by 5,000 annually. Our experience here in this Oncofert clinic has been, we have seen some 100 patients, 61 males and 39 females. Semen analysis has been performed in 37 of them, and normal semen parameters in 14. Azoospermia was found in 7, and 16 were found to have oligospermia. Among the 39 females, 14 were unfit for cryopreservation, and 3 patients are being worked up for cryopreservation. So this is another case of a 13-year female, the patient we recently had in our clinic, who had right femur earring sarcoma, which was referred to us for fertility preservation. And after the workup, she was found to be fit. However, once she was planned for ovarian stimulation followed by oocyte pickup and cryopreservation, she refused at the last moment. So this is where we have to introspect and think what could be the reason
how did this attrition happen, and what can we do as a healthcare provider? So from here, our take-home message will be always try and refer the patients for oncofertility prior to starting chemo and radio. Fertility preservation should be an option for all patients undergoing gonadotoxic treatment. The referral pathway between the oncologist and the fertility specialist. Ovarian cryopreservation for all post-prenatal unmarried females undergoing any radio or chemo. Ovarian tissue cryopreservation shall be the only method restoring both reproductive and endocrine function of the ovary. In vitro maturation, which is an innovative technique, GnRH agonist can be used and ovarian transposition can be used.
Thank you very much. Thanks, ma'am. So we now start with novel service that we started in 2017. And with the first transplant that we did in 2017, we have gone ahead and done 56 till now, including autologous and allogenic, including for some rare disorders too. So the process of the transplant after the acute care involves admission, which is for about 30 to 45 days. And during that time, there is intensive supportive care, control of infections, febrile neutropenia, and management of acute GVHD. Followed by the follow-up in the survivorship clinic, which is for monitoring for relapse and toxicities, and primarily for chronic GVHD. So this is one of our patients being followed up in the clinic with extensive skin GVHD. He is a patient with AML, has subsequently gone ahead and done well. Then this patient had, due to the steroid treatment for chronic GVHD, he had extensive necrosis of the femora head, but ultimately he did well. And this is the sister who was the donor for this child with a relapsed high-risk ALL. And finally, we go ahead with integration into mainstream, wherein we look into schooling, fertility preservation, and psychological and social integration. So this was our first transplant patient as a student of class 2, and he was diagnosed with refractory Burkitt's lymphoma, and he's presently in class 8 doing well. So the TBI that we give in conditioning for transplant, and we have given it to 7, and most of them have done well. This, along with the high-dose chemotherapy and supplemented by the chronic GVHD they have, this leads to multi-organ side effects, and that entails us to take multidisciplinary care so that an optimal outcome for these children can be achieved. Few highlights along this process have been that we have been the first in AIIMS to use immunotherapy for relapsed ALL in the pediatric population. This is blinatumomab, followed by a haploidentical transplant from the father for the patient. The patient is presently doing well. One of the few public government centers in the country that's doing haploidentical half-match transplants for pediatric patients. So with half-match transplants, the birth of donors is taken care of, and we don't have to wait for a matched donor. And also, one of the few in the country, as well as the first in AIIMS, to do the registry-based transplant for few rare disorders in pediatrics. So this is our HSCT area. It's the old private ward in the 5th floor, and it's a common ward wherein there is these rooms are the normal isolation rooms, and without positive pressure and HEPA filter, which is normally recommended for HSCT, we have achieved optimal outcomes which is comparable to what has been described in literature for both our autologous as well as our allogenic cohort. So these are few of our patients undergoing their transplant procedures, and the very same patients in the follow-up survivorship clinic. And these are 2 patients with a rare malignancy called JMML, and these are about 2 years post-transplant doing well. I now invite ma'am to carry it further.
Thank you, Dr. Aditya, Dr. Neeta, and Shivam for your presentations. We now move ahead to another important area. So cancer treatment is a teamwork, and we get a lot of support from the foundations, the non-government organizations that we work with. So I would invite one of our deemed residents, Dr. Aditya, to quickly show us how their participation has enhanced our services.
Thank you, ma'am. So, health is defined as a state of complete social, mental, and physical well-being, along with spiritual well-being as well. So in the past 45 minutes, we have talked a lot about the physical and mental well-being, but we have to realize that our cancer survivors are not just some survivors, they have to be functioning members of the society and contribute to the society. So I'll start first with certain success stories of our cancer survivors. So we have one of our cancer survivors, Pushpa, who in fact cracked the IIT exam, is currently doing computer science in IIT Roper. It was covered by Times of India as well. There's another survivor, Saurabh. He's in fact a medical student. He in fact texted yesterday that he has just passed his first year in exams. MBBS exam is going into second year. And another survivor who unfortunately lost both the eyes but still has been integrated into the system using Brady, that is Pawan. So like I said, the goal is not just cure. The goal is not just the physical well-being, the goal is not just mental well-being, but a complete social, physical, mental, and spiritual well-being of our survivors. The goal is to make them self-sufficient, self-reliant, with the successful reintegration into the society. For this, we receive, and we are thankful for all the help that we receive from our philanthropic and NGO support staff and the national government organizations who have contributed and given more than 324 scholarships in the past 5 years. A lot of the times, the survivors and the parents, they have actually exhausted a lot of resources for just the initial goal, that is cure. And now, because of the scholarships, because of the monetary and the non-monetary help provided by the NGOs and the philanthropic organization, these individuals and these success stories are there contributing to the society. Not just education, we have a immunization drive that has been going on since the beginning of the immunization clinic. With the recent budget speech by Dr. Nirmala Sitharaman emphasizing the need for HPV vaccine, that need has been coming up and has been recognized by the government today in 2024. But for our cancer survivors, again, thanks to CanKids, thanks to our NGOs, we have been doing HPV vaccination and all the other vaccination recommended, apart from the ones in the national immunization schedule, for all our cancer survivors. Like I said, we want our survivors to have a healthy body and healthy mind. There is a dedicated psychologist supported by Indian Cancer Society and a dedicated dietitian supported by Cuddles organization who has been giving dietary supplements and have been providing psychosocial support to our survivors. They also have been helping us in doing rehabilitation with the help of prostheses, implants, and recently, as Dr. Neeta and our colleagues in OBS-Gynae have discussed, with fertility preservation. We have a support group, Sambhav, where one survivor actually interacts with the ongoing treatment or patients who are ongoing treatment, giving them hope, giving them motivation, telling them that yes, cancer survival is possible, cancer survival is Sambhav. So the common thread, like I've told, is all our NGOs and philanthropic organization. A big shout out and thank you to all of them for all the help, for all the teamwork they have done for all of us. Now I invite ma'am again to speak.
Just almost reached 5 o'clock. I'll quickly sum up. So taking the survivorship at the national level, what has been our contribution? So we are heading the survivorship and late effects subcommittee at the INPOG. The INPOG is the Indian National Pediatric Hematology Oncology Group. This is the group of the PHO chapter, that is the Pediatric Hematology Oncology chapter of the Indian Academy of Pediatrics. A lot of activities are undertaken in this group. We've actually recently launched, and it is accepted, the first consensus statement on setting up of survivorship clinics in India. So this will form the baseline, the platform on which further refinements for survivorship clinics will be made in the country. And also we've launched the first childhood cancer survivorship study. This was started in 2016. So I'll just quickly take you through this. So this is a study. This was launched in 2016. The aim was to formulate a multi-center national-wide registry for children who are completing treatment, so as to provide a denominator so that we have statistics on children who are completing treatment, who are relapsing, and who are abandoning the follow-up. So also, this would form a baseline to throw light on the surveillance of second cancers, because we know there is a 15-fold increased incidence of second cancers developing in our children who are long-term survivors, that is post 5 years of completion of treatment. Also, this would contribute to development of our first childhood cancer survivorship cohort in India, and this would ultimately culminate in formulating guidelines for long-term follow-up of our cancer survivors. Till now, we are following guidelines that have been laid by the Western countries, but then soon we should in the next decade or so, we should have our own country-specific guidelines, and we have almost 21 centers who are contributing to this registry and have enrolled 3,448 patients since 2016. And this is what I just told you. There are a number of cohorts worldwide, and India is soon, and we've sort of put the foundation of our own cohort, our own survivorship cohort. So from this cohort, I thought I'll just quickly show you our data. This is the AIIMS data from the 3,400 plus patients. This is to the tune of 960 survivors that we have enrolled in this study from 2016. Majority are males, and most of these are coming into one of the forms of low socioeconomic strata. Most of the children, when they were diagnosed, were under 5 years of age. And if you see what we have discussed, the long-term survivors, those who are into post 5 years of treatment, are, as of now, also we have 23% of these children. So now we are sort of assured that the primary disease is not going to come back. They now need a surveillance for other late effects and second neoplasms. The disease profile is that majority of these are constituted by acute lymphoblastic leukemia, retinoblastoma, Hodgkin lymphoma, AML, and the other rest of the tumors, including the solid tumors and including CNS tumors. But then the numbers are less because we have ventured into this program recently. And we have full details of therapy exposures in this as part of this study. So now we know which patients have received chemotherapy, which have received radiation, surgery, blood component therapy, who have undergone a transplant, and chemotherapy was our sort of most prevalent exposure. And we have all the data available, and we are in that state that we can provide to the investigators a cohort which they require, on which further studies is a platform on which further studies can be conceptualized. What is the current status of these patients? Of these 960 patients, almost 90% are alive without disease from 2016 onwards. 1.6 are alive with disease. We've lost to their very, very low abandonment rate of about less than 1%, and about 8% have expired due to relapse or to unrelated causes. The median period of follow-up of these patients is about 3 years, 2.7 years from the treatment completion, and 4.5 years from diagnosis. So to summarize, childhood cancer survivorship has attracted attention globally, particularly because there are decades of life that are remaining for these patients. All this is culminated into increased population of childhood cancer survivors, and the intent is to only improve their quality of life and that they integrate into society well. They are going to grow into adulthood, but at a cost, where again chronic health conditions and late effects become a concern. Again, then the concept of exposure and risks, etc., need to be understood very well so that the late effects can be studied in detail. Now the focus of pediatric oncology fraternity is not cure at all cost, which was a few years ago. It is now equivalent cure with minimal cost. And long-term follow-up is the need of the hour, and the most popular means would be the survivorship clinics, and that's the model that we follow. And with this, I thank I really thank all the people who are working with us. Really, I need to mention our entire team, our nurses, our social workers, our dietitian, our counselors, our NGO partners, our other foundations who are working with us, various divisions in the Department of Pediatrics, the departments. We get tremendous support from our departments of pathology, hematopathology, radiodiagnosis, nuclear medicine, pediatric surgery, radiation oncology, ophthalmology, neurosurgery, oncoanesthesia, obstetric gynecology, stem cell facility, transplant immunology, cardiology, and transfusion medicine. Maybe I've missed a few, but yes, cancer treatment is a teamwork, and it's a big thank you on behalf of the entire team to all the teams who are helping us achieve our goal of long-term survivorship for our patients. Before I just stop, you'll be wondering why we put up that family there. So this is actually a family of 2 cancer survivors. Both are cancer survivors. One was a twice cancer survivor. The lady had leukemia as well as lymphoma. The husband was a Hodgkin lymphoma survivor, and recently they have delivered a baby girl in this institute, and that is the success of this. So we thought we'll present to you. Thank you very much. I'll ask Dr. Madhulika to speak a few words. And
thank you, the entire oncology team, Rachna, Aditya, Dr. Meena, and the whole oncology team for this very nice presentation. And I would like to congratulate the whole team. They have really come a long way from the initial beginning, which was very small. And now the survivorship clinic is a very big milestone which you have achieved. And a special thanks for the HSCT services which have been started, because our rare disease patients are also getting benefit from this. Thank you very much and congratulations.
Happy to take some questions or any comments by anybody. Dr. Rakesh, do you want to make any comments? Venkat, anybody? Meeta, anything?
I think the team is wonderful. We are having radio conference every Tuesday, 2 o'clock, and it's for the patient care. I've seen like we are having a lot of radio conferences. This unit is doing wonderful work. They are very meticulous. Follow-up is so regular, and they know each and every child name and their serial scans, and I love to be there whenever I get a chance. Thank you, ma'am, and congratulations.
I also wanted to say that it has been a pleasure to start the pediatric pathology services, which is primarily focused, it used to be focused on the pediatric surgeons, but now it has almost completely switched to the pediatric oncologists. Who, I think the systematic way in which people are being approached, the way these new clinics and new systems are being set up. So it is really good that finally we are having, DM also. These are all wonderful things, and I really see this the new switch to the MCH should result in I think newer services, newer diagnostic services, newer molecular biology, molecular pathology services should come up. So I think molecular pathology is the future for pathology, and it is also the future for oncology. And we should, I think, focus on setting up more pathology, which is at the forefront. We are actually little behind, I would say, and we need to jump to the next level, which is spatial transcriptomics. Should directly go there. This will happen side by side, but we should really think about that.
Thank you. Thank you very much. Any other comments or questions? Dr. Ahit, Dr. Rakesh, any comments? Dr. Anchal, anybody? Dr. Kanaram, anything we closed in? Okay. Dr. Neeta, anything from your side? So I think thank you all for attending this, and thank you very much.